So this is how MFTs can pay attention to sexual ethics. The purpose of this chapter is to discuss how MFTs lack training and education when dealing with clients on the topic of sex or sexuality. Sexual ethics discusses how we as MFTs have an obligation to foster a safe environment to talk about all of our clients' needs, as well as well as their sexual needs. As a country, we have had 40 years of abstinence-only sex education, and we've been conditioned to believe in heteronormative standards, and even that we may be uncomfortable talking about. Clinicians lack knowledge and awareness about their own beliefs related to sexuality, and this can affect their clients as well. So the ethics that are involved in this subject of sexual ethics. In this topic, I decided to go to address creating an open environment free of discrimination. This goes with the AAMFT Standard 1.1, non-discrimination. We're dealing with individuals and couples that may be heterosexual, LGBTQ+, and there are also sexual minority populations which engage in kink, BDSM, polyamory, and different erotofantasy sexual orientations. MFTs aren't to discriminate. And just as we check our racial biases, we also need to be aware of our sexual biases. The second thing I want to talk about was protecting confidentiality. We may be dealing with sensitive information about one's sexual history or sexual interests, and then being aware of having your clients be aware of the limits of confidentiality and maintaining it when inviting a spouse or a partner in the room, and obtaining necessary consent when disclosing information. And this applies to AAMFT Standard 2.1, confidentiality. MFTs respect and guard the confidences of each individual client. And the third ethic involved is addressing sexual issues competently and ethically. So MFTs must be competent and appropriately trained, culturally sensitive, and aware of their own biases. Gaining competency is learning to develop the language you need to talk about sex, learn common terms for various sexual gender orientations, and becoming familiar of sexual minorities and sexual minority practices. This is in line with AAMFT Standard 3.1, maintenance of competency. So regarding the Ethics Code 1.1, non-discrimination, and how it affects our clients in this situation. So this protects our clients from being discriminated against regardless of their sexual orientation, gender identity, or relationship status. While it's important to be aware of clients' backgrounds, we can't assume that every problem is rooted in contextual factors because the client's background is different than therapists. These standards are put in place for the client, and they're there to ensure that all individuals have equal access to care, and also to foster trust in a safe environment, and to offer a space that offers respect and without prejudice. And it's our responsibility to be culturally competent, addressing potential biases, and ensuring that therapy is respectful of diverse backgrounds, and that we treat our clients fairly regardless of their identity or their background, and understanding that there are diverse forms of sexual expression. And approximately 10 to 15% of people express alternative forms of sexuality. So that's a large part of your population of people that you might be dealing with. And of those, only 25 or maybe 25% of them don't even disclose to their therapists their sexual interests or this part of them because they have so much shame behind that. So we have to really be open to embracing individuals and being able to give them a safe place to talk and to discuss all the issues that they have going on with them, especially things regarding their sexual well-being. The Ethics Code 2.1, which is disclosing limits to confidentiality. This protects clients and other parties by disclosing at the outset of services the nature of confidentiality and possible limits to the rights of confidentiality. It's important that we're continually reviewing this, especially if we invite a spouse or a partner to join the session. Everyone needs to be aware of informed consent, confidentiality, and the limits to confidentiality. And we need to maintain the confidence of everyone in the room. There may be things that your individual client has shared with you that they have not yet brought up to their spouse or partner regarding their sexuality, sexual preferences, or sexual history. There may be a lot of shame and fear of judgment or criticism, regarding that. So it has to be on their own terms and of course, at their discretion to disclose that. And then the regarding AAMFT 3.1, maintenance of competency. This protects clients by ensuring that MFTs pursue knowledge of new developments and gain knowledge in sex education and maintain competency through ongoing education and training. It's important that we're continually learning more about human sexuality and growing in order to support our clients, staying current on professional guidelines and topics that may affect our clients, ensure that we're upholding ethical standards. There's a need for further training and education for addressing sexual interest topics as the culture starts to discuss these stigmatized sex practices. And if we don't address our clients' sexual well-being, we are missing out on an integral part of their human experience. And this is just in line with our education is only preparing us with one semester of human sexuality. And that's probably not enough to encompass what is a very big part of people's personality. And something that's why we need to have ongoing education and knowledge and be constantly learning about as our environment and the culture changes. We need to be changing along with it. So some of the gray areas regarding these ethics are regarding discrimination. Is if we're working with a particular population and we decide to refer them out, are we referring them out based on our own discomfort of talking about the subject? Are we like not being curious about what it is? And if it is an area that we could help them with based on our previous knowledge? Or is it that we are generally referring somebody out because it's out of our expertise or out of our competence level? So we have to be aware of that we're not using discrimination as an excuse to refer somebody out. The second topic would be the 2.1, confidentiality. So again, like when we invite a spouse or a partner in the session, we're creating a dual relationship. And again, we need to be cognizant of that the things that were shared with our individual client, that those are things that they are going to be responsible for disclosing on their own. And, maybe we're helping with them with that, but that has to be on their own terms. It's not anything that we would do for them. And the third point, which could be a gray area, would be 3.1, maintenance of competency. So when we are seeing a client whose issue might fall out of our area of expertise, knowing when to seek consultation, and then being upfront with your client and knowing when to refer out when it's beyond your scope of competence. So the vignette or the dilemma that I came across was actually a vignette that was in the book Systemic Ethics. It was regarding, it's a condensed version of that, but it was just regarding a couple that comes to a therapist because of marital distress. The couple was able to receive help from the therapist regarding communication. They were very experienced couples therapists in that aspect. And so the therapist was able to help them with their communication style. But the husband had expressed many times his desire for his wife to be more assertive in the bedroom. And the therapist kept directing that attention on how to be romantic and how to initiate date nights, which would be standard practice in like a regular heteronormative couple, and how you would maybe deal with a couple in that situation. But the therapist glossing over the husband many times, talking about his wife being more assertive in the bedroom, was his attempt to approach the subject. And the therapist was not experienced in that, and would switch it back more towards communication styles instead of actually addressing what it could possibly, what are some other, what would be the reasoning behind the husband wanting to be more assertive in the bedroom. Where does that stem from? And then exploring that more in the therapy room and as a couple and as an intermediary for the couple as well. So the husband not being able to express that in the therapy session is then essentially not satisfied with the situation that he's in. And eventually the husband resorts to exploring this desire with a paid dominatrix. He eventually admits this to his wife with shame. And the question is could this possibly been avoided if the therapist was more curious regarding the husband's desires? And, maybe picking up on those cues of the husband wanting to talk about, being dominating in the sexual relation, or his wife being more dominating in the sexual relationship. Because of that, the therapist missed an opportunity to use this context of sexual desire and apply it relationally to help the couple expand their sexual intimacy and deepen their connection. And then to be ethically and culturally competent means we don't let our biases and discomfort get in the way of assessment and treatment interventions. So how can this be applied to other professions? I chose a medical doctor. They have ethics that they have to deal with. They have standards of law and ethics to uphold, similar to us. And their clients might be having questions about their sexual health. And patients can feel uncomfortable asking questions, and doctors can also feel awkward answering questions about sexual health. So there could be possible health conditions. If the doctor fails to ask questions about sex, they might miss important information that could lead to a better understanding of the patient. And if they are just open to asking questions to the patient, it's how is your sexual health? They allow the patient the opportunity to bring up things of concern that, ultimately the doctor might be able to help them with. So the doctor does have competence because it's in their realm of competence and expertise to deal with issues like sexual dysfunction, which could be a medical condition, or lack of pleasure, which could stem from depression. That's definitely something that's within the competence and expertise of a medical doctor to deal with. So that was my comparison about that. And I chose this media clip from called Say More, Esther Perel on Fantasy with Gillian Anderson. Where should we begin with Esther Perel? She is a psychotherapist, and she specializes in talking about sexual intimacy and how couples and individuals can get out of the normative standards that we've been set by our culture. And it's a good and interesting. She talks a lot about different ways that even in a marriage that you can still find the passion that people feel like they're missing in, you know, their regular marriages. But beyond that, it's about about finding these things that create intimacy and connection within people to make them feel more fulfilled in their sexual lives. And then these are my references. And that's it. Thank you so much for your time, and hope you have a great rest of the day.